시청자 여러분, 안녕하십니까? 현대의학과 건강 백세를 담당하고 있는 신경내과 전문의 전희택입니다. 오늘은 신경외과의 최첨단 수술인 뇌심층 자극 수술의 선구자이시고 UCLA 신경외과 교수이신 네이더 포라티안 박사를 모셨습니다. 포라티안 박사님은 1996년에 UCLA 학부를 숨마 쿰 라우데로 졸업하시고 2003년에는 MD와 PhD를 받으신 후 버지니아 대학원 신경외과 수련을 거치신 후 2009년에 다시 UCLA 대학병원에 오셔서 현재는 신경외과 뇌심층 자극 수술의 책임자로 일하고 계십니다. 그러면 Dr. Pouratian을 모시겠습니다. Dr. Pouratian, thank you very much for coming over to our audience.
Thank you very much for having me.
So how was the traffic from UCLA today?
As usual, there was a lot of traffic, but I'm glad I was able to make it.
I'm glad too. So let me just get to the point. Now, what is the deep brain stimulation?
The simplest way to think of deep brain stimulation is like a pacemaker for the brain.
Okay.
Everyone is very familiar with pacemakers that we use in the heart,
Correct.
which keeps the heart beating at a constant rhythm.
Right.
The pacemaker for the brain, or the deep brain stimulator, is very similar, except that instead of stimulating the heart, we're stimulating the brain.
Okay.
And we target it to very specific areas depending on the disease that we're treating. So for Parkinson's disease, we have certain areas of the brain that we place the stimulator. For essential tremor, other areas of the brain. And now we're exploring many other diseases to treat with deep brain stimulation as well.
Correct. Before we go too far, let's talk about the system itself a little more. Now, deep brain stimulation is a kind of system that involves 3 or 4 components, right?
Yes.
So tell us about what components we're talking about and where does it go to your body.
Okay, so if I may, I can show you the device. Sure. So this is an example of the type of lead or electrode that we place in the brain.
Correct.
And you can see it's a very small and precise lead that ends up in the human brain in a very particular area. This is the device that we place deep into the brain, and usually one wire on each side of the head.
Okay.
Okay. These wires then travel behind the ear and under the skin, and we place a generator that is just like a pacemaker into the chest that connects to...
Under the skin.
Yes, everything is under the skin. And this connects to the leads that go into the brain. This device here has both a battery and a generator, so it generates the electrical impulses that modulate the brain activity.
How often do you change the battery in that pacemaker?
So these batteries will last usually between 3 and 5 years.
It'll be a very brief procedure to change the battery.
So to exchange the battery is a very simple procedure. It takes about 20 minutes, and it's outpatient surgery, meaning people go home the same day.
Okay. Let me ask you about the procedure where you insert that lead, the wire from brain that will be connected to your pacemaker. Okay. How long does it take to implant the microchip in your head and wires, approximately how long it takes, and what kind of anesthesia you have to perform?
Okay. So the surgery to implant the leads in the brain usually takes somewhere about 4 to 5 hours of time.
Okay.
And there are several steps that we take to do the surgery.
Right.
The first step is to place a frame on the head, which is a system that helps us navigate through the brain. It's like a GPS system for each individual patient's brain. So the frame is very important.
Correct.
After we put the frame on, we get a CAT scan, so we know exactly what the brain looks like, and then we plan the surgery. And we plan it specifically for each patient depending on what their anatomy looks like.
Right.
And then the most important part of the surgery is when we're placing the electrodes, we map out the patient's brain, meaning we look for the effect of stimulation to make sure that the electrode is in the best possible spot. So that means that we keep the patient awake during the surgery so that they can tell us if they see an improvement.
Partially awake.
Partially awake, yes. So they are asleep for the parts of the surgery that they don't need to help us.
So,
But we wake people up for about 20 to 30 minutes so that they can help us. We can see if they have a tremor, if the tremor goes away, or if they have Parkinson's disease with stiffness and rigidity, to see that that goes away, to make sure that we have the electrode in the best spot possible.
this is the time where you will find out exactly what location your lead, the electrode, will be implanted. It's very, very important moment, so that the patient should be able to follow your commands. Is that right?
That's exactly right, because location is the most important part of this surgery. Getting the electrode in the perfect spot for the individual patient is the most important thing. Because
everybody is different, and in Parkinson's disease, if I remember correctly, there are several nucleus that you want to specifically target it, and there are several targets that you are considering before the surgery, right?
Correct. So there can be several different areas of the brain that we can put the electrode in. And every one of those areas is slightly different in every patient. So even moving this electrode by 2 millimeters can make a very big difference.
2 millimeters?
Yes.
So you can hardly see. Do you use microscope with this surgery?
We use magnification,
magnifying glass.
And we use that special frame to help us guide and do precision surgery. So, you know, the surgery is our best opportunity to help the patient the most.
Correct.
And that's why it's so important for us to wake the patient up. And I think if you ask most of our patients, it sounds a little bit frightening, and I understand, but most people have a very relaxed experience, and it's not so frightening after they're done.
You don't feel pains, no discomforts?
No, because we do the parts of the surgery that are potentially painful or uncomfortable with the patient asleep, and we only wake people up once those parts of the surgery are completed. So people really don't experience any pain. In fact, most often our patients are smiling with us, telling us jokes, and we try and make them relax during the surgery because we understand it can be a little bit anxiety provoking.
My understanding, brain itself does not have pain sensations. It's the peripheral tissues that have a pain nerve endings, but brain substance itself does not have nerve endings for the pain subsection.
That's correct. So we do the parts of the surgery that can be painful, like opening the incision and opening the covering of the brain.
Right.
Once those parts are done and we no longer are potentially causing any discomfort, that's when we wake the patient
Inside
up.
The brain, we don't feel anything.
Right. So
even if you stretch my brain, I'm not going to feel it, right?
That's right. So like I said, when we might have to move the electrode even 2 millimeters, patients don't feel that. They don't feel anything at all. They don't feel pain. They don't feel anything from the movement.
Amazing. So once you finish that, then you will connect that wire to the pacemaker into your pulse generator.
Yes.
And after the surgery, you're able to control or adjust the frequencies of the currents or the amplitude. So tell us about how you regulate the electrical functions of this system.
Okay, so as you've suggested, the surgery is a big part of the treatment.
Correct.
But just as important is after the surgery, the programming of the device, and then the medical management. So I'm going to draw the analogy with the pacemaker for the heart again.
Okay.
So just like we can change the frequency or rhythm that a pacemaker can control the heart, we can change the frequency and rhythm with which we stimulate the brain. And again, because every patient is different and every patient's brain is different, the precise frequency, the amplitude, the pulse width may be slightly different for each patient, and we optimize that based on how patients are doing clinically. And it's not a single visit, so it's not that people come in for one visit after surgery, we find the parameters and we turn it on. Because the brain is a very smart organ, and it adapts. So we can start, and people do well, but after several weeks, sometimes the brain goes back to where it was before, and we need to make further adjustments. So usually we tell people that we expect about 3 months, but maybe 4 or 5 months of programming before they have a steady response to the therapy.
So how often do you see this patient in general?
For the first few months after surgery, we'll see them once to twice a month. And then after the third or fourth month, we'll see them about every 3 to 6 months, depending on how they're doing as well. I will add the other very important factor after the surgery is not just the programming of the stimulator, but it's the adjustment of the medications. Mm-hmm. Because, for example, in Parkinson's disease, when we implant these stimulators, sometimes people have such a dramatic improvement that they need to reduce the amount of medications that they take or change the schedule of their medications.
Correct.
And so that's why I work very closely with my colleagues in neurology, neurologists who are specialists in movement disorders, who then help adjust the medications and make sure that we optimize the entire patient, not just the stimulation.
So the patient will continue to be followed by her or his neurologist for the medication dosage. In some patients, especially with the simple tremors alone, may not require any significant amount of medications. Is that correct?
That's correct. So depending on the diagnosis, you may or may not require medications after the surgery. So for people with essential tremor, which is actually the most common cause of tremor, when we use deep brain stimulation in those patients, many don't require medications at all after the surgery.
That's what I hear. Some musicians, like a violinist who were unable to play violin after the surgery, she went back to performance without any medications.
Right.
So what other conditions do you implant this so-called DBS, Deep Brain Stimulator?
So the most common condition that we implant the deep brain stimulator for is for Parkinson's disease. And it treats the primary movement problems of Parkinson's disease. So it will help with patients who have stiffness, slowness, as well as tremor. It'll also help the patients with Parkinson's disease who develop the medical complications of the medicines, which is the dyskinesias, or the increased movements.
Abnormal movements.
Right, abnormal movements related to the medications. Right. So we treat Parkinson's disease is the #1 disease because of the disability associated with it.
Correct.
But the other disease that we treat quite often is essential tremor, which is actually 10 times more common than Parkinson's disease. But we tend to treat fewer patients only because it's not usually as disabling as Parkinson's disease is. An essential tremor, the tremor is a little bit different than Parkinson's disease because the tremor is usually with an activity, like with eating, with brushing teeth, or with trying to write. And some people develop this tremor very early on in life, in the 20s or 30s, and those people can become very disabled. But we've treated people with essential tremor from as young as in their 20s up until someone who is in his 90s.
Right.
So it very much depends on the individual patient and how disabled they are.
Right. So this essential tremors, patients normally do not have associated stiffness of the body, rigidities. That is why this condition is called essential tremors. Is that right? I mean, single problem is the tremor most of the time.
That's exactly right. So it's different from Parkinson's disease because it does not have the stiffness or rigidity. It does not have the slowness of movement. It's a pure tremor. Right. And the other difference between Parkinson's and essential tremor is that the tremor for Parkinson's disease is usually at rest, whereas the tremor for essential tremor is usually with movement.
Movements. What other conditions have you treated lately? I hear some psychiatric disorders like severe depressions, obsessive compulsive disorders.
Yes, so because of the success of deep brain stimulation for movement disorders, there's been a lot of interest in treating other disorders. So at UCLA, we've treated patients both as part of clinical trials and off-label, which means without the official approval of the FDA, but we tell patients that we can try the therapy. And we've treated patients in clinical trials for severe depression. We've treated patients for obsessive compulsive disorder, Tourette's syndrome, and chronic pain as well.
So what you're saying is that you're treating a variety of conditions with some type of electrical current.
Yes.
It seems like we're going back to electroconvulsive therapy, electric shock therapy.
So many people make that comparison. There's two arguments about that. One is electroconvulsive therapy is actually a very effective therapy, although it's very controversial. But the difference is also electroconvulsive therapy, you shock the entire brain. In this case, we're shocking very specific parts of the brain depending on what disease we want to treat. Because, our scientific understanding of neurological diseases and psychiatric diseases has come a very long way.
Correct.
And what we understand now is that these diseases are because the brain is not functioning in the correct way. The networks of the brain aren't functioning the correct way. And what we try to do is modulate those or change those networks to make them a little bit more normal and help people become a little bit more normal. And so we're trying it for many different diseases. The more we learn about these different diseases, the more we try and use this type of approach.
So it seems like we're understanding our brain functions a little more than before, but still we're not knowing very much about the brain. But I think we are scratching the surface very close. And the brain and computer interface is coming very close. You also doing some research about this brain and computer interface science. Is that correct?
Yes, I think it's a very exciting time because at the same time that we're learning a lot about the brain, we've had very significant advances in engineering. And when we bring those two fields together, it becomes a very exciting opportunity to do brain-computer interfacing research.
It seems like we're going back to Bionic Woman or the $6 million man era in 1970s. Is that correct?
I think we are, but the exciting thing is, in that era, it was science fiction, and now it's a reality.
Very close to reality.
We're becoming more and more of a reality. The things we dreamed of in the 70s are now much more believable. You know, we had a company, not UCLA, but there's a company in Southern California that's just developed a prosthesis or a stimulator to restore vision by placing an electrode in the eye. And we're seeing the same thing for restoring hearing.
Right. Cochlear implants been around for years.
Right.
What about this guy, Olympic sprinter called Victor Osterius? What's his name? You remember the bilaterally amputated guy who made the Olympic
South Africa.
sprints? Yeah. Is this artificial limbs somehow bionic related, or is it pure, simple prostheses?
I think his are just pure prostheses. But what we have seen is, especially the U.S. Army or Department of Defense has invested a lot of money in developing prostheses for the arm that are controlled by brain signals. And so we have the ability now to control a very dexterous or a very complex robotic limb with brain signals. I think the other thing we'll see is we're also learning how to read signals from nerves. And so those prostheses may be controlled by signals that we record off of nerves. So everything that we once thought was impossible is now becoming possible with electronics and human interface.
So the machine is directly connected to the brain function.
Yes.
What about neuromodulation? What does that terminology indicate? Is a DBS more or less invasive neuromodulation?
So neuromodulation refers to anything that we use to change activity in the brain or in the spinal cord or even the nerves. So for me as a neurosurgeon, the most common technique I use is deep brain stimulation. But there's also non-invasive neuromodulation. So there are devices that use magnets, which is something we call transcranial magnetic stimulation. There's direct transcortical stimulation, so using current to stimulate the brain. And there are also some over-the-counter products that directly stimulate the brain with electricity, which we don't know exactly if they're modulating brain activity, but they probably are in some way. They're just not as well studied. But as you suggest, there's the non-invasive methods and there's invasive methods.
So what kind of side effects can we expect from deep brain stimulation procedure, especially it involves, after all, it's a brain surgery?
Yes. So everyone is very concerned because it's a brain surgery and it's elective because you don't have to have this surgery.
That's
people
right.
can live without the surgery. But for the people who are good candidates, we tell them that the risks are very low and the potential to help them is very high. So it's worth considering. The risks, I consider three classes of risks. One is related to the implantation of the device into the brain. So there's the risk of brain injury.
Correct.
And there have been many studies looking at the risk of brain injury, and what we know is that there's about a 0.5 to 1% chance of having...
You're talking about mechanical injuries.
Mechanical injury
Injuries
causing...
related to the wire,
Yes.
The metals, microchip.
Or something, yeah,
Right.
one of those things injuring the brain.
But you're dealing with very, very small equipment, the electrical gadgets. So.
But even so, even though we make a very small incision, it's only 5 centimeters, when we put the wires in, it's possible to accidentally hit a small blood vessel.
Right.
And usually it doesn't cause a problem, but about 0.5% of the time it can cause a small stroke.
Okay.
But almost never is it...
Not a major stroke.
No, not a major stroke. Almost never is it a mortality. So people don't die from this procedure.
Right.
The other risk is from the device that's being implanted. It's actually a more concerning risk for us, which is the risk of infection.
Correct.
And it's probably about a 2 to 3% chance of infection. But the infection is very treatable. It's an infection in the
Right.
skin, not in the brain.
It's a normally expected side effects of any type of
any surgery.
Surgery.
Right. And so we can treat those infections. And the last group of side effects are related to the stimulation. Sometimes the stimulation, when we turn the device on, can cause some side effects. Some people have some speech difficulty. Some people will have a heavy feeling in their arm.
Usually those are temporary.
Exactly. So those are temporary because when we turn the stimulator down or we change the settings, those feelings go away. So it's related to the electricity. And that's why deep brain stimulation is such a great therapy. It's because it can be modified. It's not a one-time treatment. It's a treatment that we can change over time to make sure that we make the patients as comfortable as possible, give them as much benefit as possible, and reduce the risks of the treatment.
It's a very rewarding surgery. And last time I read the literature, there were 100 cases of DBS surgery. There were no mortalities. No one died from the surgery. Mm-hmm. That's remarkable.
Yeah, mortality is basically not expected at all from this.
It's not like a ordinary neurosurgery.
No, I don't even discuss mortality with my patients because it's not
right.
a real risk of the surgery.
Okay, thank you very much, Dr. Pouratian. I know you're a busy person and you made all the way from Westwood. Thank you again. I will see you at the campus. 시청자 여러분, 오늘의 의학 정보가 많은 도움 되셨으리라 믿습니다. 자세한 내용은 주치의와 상담하시 다시 읽을게. 예. 시청자 여러분, 오늘의 의학 정보가 많은 도움 되셨으리라 믿습니다. 자세한 내용은 주치의와 상담하시기 바라며 저는 다음 시간에 다시 찾아뵙겠습니다. 안녕히 계십시오. Thank you.
Thank you.